orthodontists. We know that digital orthodontics is very important and it's getting more and more important in our offices. But is it for the best or the worst for the orthodontists? So yes, I'm really involved in orthodontics. I work a lot. I work at Paris 5 University. I have also developed a laboratory, and I'm working with colleagues to develop a series of courses. But if I am really involved and passionate about orthodontics, I'm not only an orthodontist. I'm also a bass player, and I love practicing kitesurf. But anyway, let's go back to our topic and see if digital orthodontics is the future of orthodontists. Because we have to keep in mind that when a new technology is introduced, it always influences the organization of the work. And so a doctor's habits and practice have to be modified. So we need to understand it and control it. We have to understand and control the digital orthodontics, the digital flow for our benefit and advantage. So my reflection has started a long time ago, and I would like to share my story. It all started in 2006 with the European Society of Lingual Orthodontics. The meeting was held in Venice. So I remember this period of time because it was a very enthusiastic and stimulating period of time. And I remember that there was 3 major trends in lingual orthodontics. The first one was the in-office procedure using 2D lingual brackets. And the other ones was one using a manual process to create a lingual appliance. And the third one was the use of a CAD/CAM process. It was incognito, the use of a CAD/CAM process to create the lingual appliances. And in 2006 also, there was a discussion, I could say a battle between lingual doctors and aligner doctors, because aligner were the first to use digital process to create appliances. And so when I went back to my office, I started working on lingual and started appliances as well. So I had quite good results, but I was not fully satisfied by the outcome of my treatments. So I wanted to go deeper into the understanding of the appliances, lingual and aligners. And I had to do that also because in 2009, I was lucky to start working at the postgraduate diploma in lingual orthodontics at Paris 5 University. And so the student asked me many questions about how to manage the lingual appliances correctly and how to deal with the setup correctly. And the turn was in 2013, because in 2013, I started using digital flow in my office because I bought my first intraoral scanner on 3D printers. So this is the starting point of my journey with lingual and liner and 3D technology. So I tried, my wish was to develop in-office lingual procedures and in-office aligner procedures to be free from any company and to have better outcome and be able to control the movement of my teeth more efficiently. The fact is that we wanted excellence and individualization. I think that's one of the crucial points with the digital, but we need to shift our mind and to understand what is the difference between the digital setup and the manual setup, because lingual and aligner are based on setups. So we need to understand what is a setup. I would like to explain the difference between digital and manual setup with a case. So this is a young girl. She's 15 years old. And she comes to my office because she wants to correct her teeth. she's a class 2 division 2 malocclusion, as you can see. She has a severe debite, retrocline upper incisors. She has a class 1 molar and canine on the right side, but a class 2 molar and canine on the left side. You can see the crowding on both arches and the difference of shape between upper and lower arches. So the panoramic radiograph shows nothing special. It's fine, but you can see on the lateral cephalogram that she has a very severe debite and she's hypodivergent. Here with the analysis and the figures. And my goal is to correct, of course, on malocclusion. So it all started with the digital impression. So you convert the reality into the digital impression. And with this digital impression, you do the setup that is the goal to reach at the end of the treatment. We all know that we have to follow some rules to do a setup. And these rules are based on the 6 keys of occlusion of Andrews. So we know that we have to manage the tip control, the torque control, the rotation, you have to close the spaces, and you have to level the curve of Spi, and of course, to reach a good molar and canine relationship. So if you want to compare manual and digital setup, you can see that at the very beginning, the first step, which is teeth segmentation, it's exactly the same. One is a physical segmentation, and the other one is just a virtual segmentation, but the goal is exactly the same. The second point is the dental arch form. You have to determine which is the best dental arch form. So you have some template to make it match with the initial arch form, and with digital, you can place different points to establish the most appropriate dental arch form, but it's the same goal. Regarding leveling and alignment, it's the same goal as well. We need to flatten the curve of Spi. With a manual setup, you have a physical contact with a rigid flat surface. And with a digital setup, you have a virtual occlusal plane, and you have to have some balanced, smooth bilateral contacts. The difference is here. You can see that for a manual setup, you have some devices that allow you to control and to evaluate the tip and the torque of the teeth. For the digital setup, it's a little bit different. Of course, you have this kind of tools showing you the amount of movement, quantity, the degree of movement. But for me, the difference is very important because it's digital. You have in mind the initial situation. Let me explain that. You can evaluate the initial position of the incisors on the lateral cephalometric. And so you can see the position of the lower incisors in the chin. You can also evaluate the inter-incisal angle. And when you create your setup, you remember that you have transformed the reality into virtual teeth. And so I can select on this view, I can select the teeth that are going to be the references and that are not going to be moved, and those who are going to be moved in order to change the arch shape. So I don't want to move this canine. I will upright a little bit this one. And so I can draw my dental arch shape and then move the teeth to reach that limit. And you can see in this little movie that I click on the teeth and move them so that I can reach the dental arch shape I have determined. You can see that I upright the teeth. And that makes a huge difference because according to my initial evaluation, the evaluation on the lateral cephalogram, I accept to procline the lower incisors by 5 degrees. So I know that I can get to that position. It means that I'm not creating my setup according to basic rules, such as having a straight lower incisors with a 19 degrees finger. I accept to procline a little bit, and I can see the difference between the initial situation and the final situation, because the digital setup it has the memory of the initial situation. And when you have a class 2 malocclusion, you treat a class 2 malocclusion with elastics or herbs appliances or any kind of device connecting upper and lower arches. And so you know that you will have a forward movement of the lower teeth. And if your lower teeth are perfectly straight, if you push them strongly, then you can get this result, and you really move the lower incisor outside of the bone. So it's very different because now, because the digital setup has a memory of the clinical situation, of the initial clinical situation, I can incorporate in my digital setup 5 or 6 or the amount of degree you want, and having as a starting point the initial situation. So I think it's much more powerful than the manual setup. Regarding the stripping, it's the same goal. You just evaluate the overlapping, the virtual overlapping between the teeth to evaluate the amount of enamel you have to remove. For the occlusion, that's a difference between a manual and digital setup, because we are used to have physical casts in our hand and make them touch and be in contact. So we can feel the contact between upper and lower teeth with the manual setup. And for the digital setup, the approach is different because it is based on visual analysis. And we have different tools to evaluate the contacts between upper and lower teeth. So here is the setup I have created. And really keep in mind that the digital setup has a memory of the initial clinical situation, and that makes a huge difference when you want to manage the case. So let's see the clinical phases. The first one is, of course, the alignment. Because of the overbite, of the deep bite, sorry, I have placed this kind of pads, and it helps to correct the deep bite. And I use an over for night eye. I create space and change the arch form, of course. I level both arches. You can see the evolution, an 0.160 MA, and later on, I can bond the upper arches. So I have a 0.149 on the upper arch, and 17 by 25 TMA on the lower. So I start to control the torque. And later on, I can use intermaxillary elastics on both sides to correct the class 2 elastics. At the very beginning, because this upper arch is not stiff enough, I just use intermaxillary elastics at night. So the patient is used to wear elastics. And when I ask her to wear elastics 24 hours a day, it's easier for her. And then you can see the improvement of the case until the finishing stage. And here is the final situation. The final situation, fortunately, matches with what was planned on the setup. So you can see 18 months after retention and the comparison between the final and initial situation. And the improvement of the smile before and after, as well as the improvement of the face, thanks to the class 2 mechanics. Here are the final figures. And you can see the superimposition between the three stages, before treatment, after treatment, and after retention. The first point to keep in mind is that digital setup as a memory of the initial situation, so you can evaluate the difference between the initial and the final situation from the beginning when you create the setup. Another point was the introduction of the CBCT data and the combination of the STL files, it means the virtual impression, and the DICOM files from the CBCT. And I will like to illustrate this with Maxime, because sometimes when you treat a patient, it's not only about doing a treatment, it's also a human story. And this is a case with Maxime because he was really shy because of his smile, and he was really preoccupied by his smile. He's a banker, and so as a banker, he works with a lot of clients, but he was really unable to smile. And when you see the occlusion and the initial situation, you can see that the 12 and 23 are missing. The 22 is the peg lateral incisor. You can see the buccal frenum on the 24. So maybe a periodontal surgery might be necessary after the treatment. So I do the digital impression. And when I look at the panoramic radiography, I can see the impacted canine on the left side. Here is the lateral cephalogram, so it's a little bit hypodivergent, but it's quite okay. First, because it was before having a CBCT, I asked for a scanner, and you have some slices to see the relationship between the canine and the incisors. So my idea, my treatment plan was to, on the right side, to close the space to have a class 2 molar relationship. But on the left side, my idea was to create space for the canine. So I wanted to make a traction of the canine. And so I had to derotate the premolar, so you can see the position of the canine. I had to derotate the premolar and create space and move the canine to its correct place. So that's what I have started to do. First, I bond my lingual appliance. Here it is. I derotate the left premolar, create space for the canine. And when I think it's good enough, I write a letter to the surgeon to expose the canine. And at the following appointment, I was supposed to start the traction of the canine. So first of all, I do a panoramic radiography. And as you can see, there was a trouble. Actually, during the surgery, the patient asked the surgeon to remove the canine because he was not very comfortable with the canine traction. So when he came back to my office, there was no canine anymore. And he told me, that's not a problem. It's not a problem because on the right side, you can move the teeth forward. Just do the same on the left side. But the story was a little bit different because you can see the thickness of the bone. And on the left side, it's going to be very difficult to move my premolar forward and move my premolar at the same place as the canine. But I started and tried to move forward my canine. And as you can see, it's very difficult because of the thickness of the bone. Here is the evolution. So on the right side is fine. I can move the premolar forward, and I know that I can reach my goal and get a class 2 molar relationship. But on the left side, you can see the evolution. And at this stage, I was unable to move anymore my premolar. So I need to do a re-evaluation of the case. And then in that situation, it was really useful to have a CBCT because I took a new impression, you can see, and I've done a CBCT. Here is my CBCT file. You can see the relationship between the premolar and the bone. And frankly, when I saw these pictures, I was really scared because you can see that there is no bone on the labial side of the premolar. And here another view, you can see that the thickness is terrible for me to move the teeth. So I have to find a new solution. And the idea was to combine the CBCT file with the STL file. So I can create a new setup and move my roots where the bone was available. So you can see that I can improve the axis of the anterior teeth. And regarding my premolar, I knew that I had no bone on the labial surface. So I had to move my roots palatally to have the bone, the palatal bone that was available. I know that I was unable to move my roots mesially. So it was more about having a tipping of my premolar. So I have done this movement virtually, and this is the initial situation. And you can see that I have moved palatally my roots and make a mesial tipping of the crown so that I can reach that situation. And this is a very powerful tool because when I do that, you can see the aesthetic simulation. Well, I can send my file to a GP, my colleague with dentist, and ask him if the situation of the tooth, if the simulation was fine enough for him to create aesthetic restoration after my treatment. And so he was able to validate my setup and said, okay, if you can reach this position, I can do a reconstruction, a restoration of the teeth. And so with this new goal in mind, I have been able to make a new appliance, a new lingual appliance, and then move the teeth to reach this final situation so that my colleague was able to do the prosthetic and adhesive restoration. So it looks easy when you hear it, but the story was a little bit more complicated because if it seems to be a simplification of the communication and a very fast communication between the dentist and the orthodontist, we have to face a lot of problem of software compatibility because he worked on a system with one software and I was working with another software. But finally, at the end, we have been able to reach this result. So I think regarding the initial situation and challenges that we have to face, it's quite a good result. You can compare the initial situation and here the final situation with the restoration. And despite the improvement of the smile, he was still smiling very shyly. Initial situation and after the orthodontic treatment, and the final situation with the aesthetic restoration. So one of the major points is the digitalization of the patient and the opportunity to have a collaborative CAD/CAM procedure to treat patient, collaborative procedure with a dentist. But digital is not only about that. We have discussed the static setup. It means the setup for the lingual appliances. And what is a static setup? What do I call a static setup? Here is the initial situation. Here is the final situation. So it's like when you go up on stairs, you are free to follow the path you want. You can go on the left side. You have fewer steps, but the path is longer. Or you can go straight to the top, but you have more steps before reaching the stop. But if you compare that with the clinical situation, you have different ways to treat the patient. And sometimes it's easy. You can use the green or the purple way. But the fact is that in clinic, usually you have to move from one option to the other and follow the orange line because you have to adapt your treatment to the evolution of the clinical situation. And that's exactly what had happened with my previous patient. So we know this kind of setup, but setups are also useful now to do aligners. And I think there is a misconception of the setup for aligners. And then I want to oppose the static setups with the animated setups. What do I call an animated setups? Animated setups are setups for aligners. You have one step, then another one, and another one up to the end of the treatment. So the difference is that each step is like a unique setup. It means that if you want to have a good final outcome, 100% of each setup must be converted into movement. So each aligner must be efficient and deliver all its information. And so I started doing my own aligner, and therefore I was the one who was able to select the best path to move my teeth and get the result. Because when you use aligner with the company, this is the company who determines the path you have to use to get the final outcome. So I started doing my own aligners, and it has helped me to understand clearly the clinical value of the setup. I would like to illustrate this with Theo. Theo is a 13-year-old boy. His chief complaint is the diastema between the two central incisors, and he has also proclined upper incisors. So here is his face. So he doesn't like his smile, but when you look at more precisely, you can see that he doesn't like the toothbrush either, because he has not a very good oral hygiene. Anyway, so the good point is that he starts with a class 1 molar and canine on both sides. So that looks like being an easy treatment, but you can see that he has a deep bite, procline upper and lower incisors. I have no overjet, as you can see. And you know that when you move backward, when you move palatally the incisors, you have a vertical extrusion of the incisors that will increase the deep bite. So I will have to manage that when I will do my setup. On the panoramic radiograph, okay, it's fine. So if I want to summarize the situation, the patient is a class 2 hypodivergent. He has a dental class 2 brie protrusion and a deep bite. My treatment goals are to close diastema and to control the deep bite. And because of his poor oral hygiene, I have to have a very short treatment time. And I think that aligners would be a good solution for him to be treated. And here is the first step. The first step for aligners, for homemade aligners, yes, is to bond attachment. How do I create my attachment? I'm not using a template. I'm just placing a single drop of fluid resin and teeth. And that's enough. When you want to when you want to grab the teeth, you just have to create to create a surface that will be easier to be caught by the aligner. So just a single drop of fluid resin is enough. I would say it's not a bracket science. It's just about creating some smooth kind of smooth button of fluid resin. And then I do my intraoral scanner and to transform the clinical situation into the virtual situation. So you can see that my STL file shows the attachment. And the third step, of course, is a laboratory assistance and the simulation. So let's have a look at the upper arch simulation. This was the initial situation. It was my really first case treated in my office with the in-office CAD/CAM procedure. So I wanted to be very ambitious, and you can see the movement of the incisors. But let's have a look also at the molar movement. And you can see only 6 steps were necessary to reach the final situation. On the lower arch, it was exactly the same, 6 steps. So you can see the initial situation, step 1, 2, and look at the molar, 3, and so on. At the 5th step, I think it was a good situation, but I had more information and overcorrection on the incisor on the 6th step. And then in my office, I printed the models and created the aligners. What about the clinical evaluation? You can see the aligners in mouth. Is it aesthetics enough? Yes, it is. The patient is wearing his aligners. You can see nothing. Is it effective? Let's have a look at the end of the treatment. Well, here is the final outcome. You can see here, I have maintained, of course, I have maintained the class 1 molar and canine relationship on both sides. I think the upper and lower arch shape is very nice. How did I do that? What is my in-office organization? Of course, there is the first consultation. Then I do my diagnosis, my impression with the attachment, my prescription form, so I can ask my nurse to do the setup and sequencing of the setup. I validate the setup and the sequencing, and then my nurse can produce the aligners, and I deliver the aligners to the patient, and I check after the 6 aligners were worn. So the comparison, here it is, the initial situation, and then the final situation. So only with 6 aligners were changed every 2 weeks. Initial and final situation, a good incisor repositioning on the left side, and look at the modification of the upper arch, initial and final situation, and it matches with the setup, lower arch, initial and final situation. It matches as well with the setup. But I think the superimposition of this kind of images is not very good. We can do better. We are in 3D now. We are in the digital world. So I wanted to evaluate the accuracy of my method by superimposing my setup with my end of treatment file. So I do an intraoral scanner of the end of the treatment, and I superimposed my setup, my end of treatment setup with my end of treatment results. And you can see here that there is a slight difference, which is in yellow and blue. When it's white, it means that it matches perfectly. And you can see that the teeth, which are hard tissue, so that means that their movement is really reproducible. You can see that they are all white except for the tooth number 17, just because it's much more difficult to move teeth with a short crown. But you can see that the movement of the incisors, canine and premolar, is very accurate and reliable. On the lower arch, we have the same observation. Molars, which were more difficult to move, and so they did not reach 100% of the simulation. On the contrary of the incisors and premolar, who reach exactly the final position that was planned on the setup. So the conclusion of this case is that we have only done 3 months of treatment with 6 aligners, one every 2 weeks. Okay, but one case is not enough. And I think we can go further. But the conclusion of this first case was CAD/CAM procedure were instrumental and crucial for aligner therapy. And that now I can design and produce my own aligners very efficiently. And then I wanted to do a much more difficult case. And look at this patient. So Abderrahman is 50-year-old man. He's a very interesting person because he's professor at the university and he teaches IT. He's a professor in IT, so he's a really big fan of digital. And when I explained him what was the new solution with these new digital tools, he was really okay to have this kind of treatment. But when you look at these teeth, you know that it's going to be a little bit more difficult than the previous case. So he has a diastema, anterior diastema. His face is balanced, so that's fine. But when you look at the intraoral pictures, you can see that he has a severe periodontal problem with a B protrusion and procline anterior teeth. He also has a prosthetic crown on the first lower right incisors. And I don't know if you can see anything else on these pictures. Okay, if you can't, I will show you a closer view of the upper arch. And then you can see that the teeth are bonded by group of teeth to create a kind of periodontal retention. That means that when I will have to do my simulation, I'm not going to move single tooth. I'm going to move a group of teeth. So from a biomechanical point of view, it's very different, and it's going to be a little bit more tricky. Okay, anything else to say about this case? So let's go further and let's analyze the panoramic radiography. And another problem, the crown on the lower arch was not only a crown, it was an implant. And so the panoramic radiograph confirms the periodontal disease, and it confirms also that there is an implant. And we know that we cannot move an implant. On the lateral cephalogram, you can see that there is no overjet. You can see that the upper teeth and lower teeth are proclined. And so how can I manage that? How can I correct my upper incisors position and manage the problem of my implant? What would you do? Well, what I have done, what I did, is that I took a burr and I grinded I grinded the crown to reduce the size and modify the shape. So here is after grinding the crown. Then I have created an overjet by reducing the shape of the crown. And with a few aligners, I can have a good alignment of the teeth and reach this final situation on the lower arch. What about the upper arch? How did I do to manage the biomechanics with a group of teeth? Well, everything is about the simulation. So I have to be very gentle and very careful regarding the tooth movement. And you can see the improvement of the alignment. At this stage, I have a problem of tipping of the right upper central incisor. So I broke the composite between the two central incisors. So I was able to upright the tooth 21. And here is the final situation. And you can compare initial with the final situation. You can see the good repositioning of the teeth, although we started by moving a group of teeth and not only a single teeth. And what I really like is this view. With this view, I can see that I have a very smooth contact between upper and lower teeth. And I think it's very important to have a good anterior contact between incisors, especially when you have a periodontal disease. You don't want an overload in the occlusal contacts. Initial situation and final smile. I think we have done a good work for this patient. So at this stage of the lecture, we have introduced the in-office CAD/CAM procedure and the collaborative CAD/CAM procedure. And I think now the collaborative CAD/CAM procedure is a very mature concept. Let me show this with this slide. And the idea was to make a digital impression and internalize the entire process of designing and manufacturing the appliances. So in my in-office CAD/CAM procedure, I do the conception by myself, design. I do the in-office printing and the thermoforming on the aligners. When you externalize with a company, you do almost nothing. You externalize the entire supply chain. So you just get the aligner at the end by post mail. And I think the new concept is that now we can introduce a higher level of control of the practitioner, because now we can do the conception, the design in our office. And if we don't want to print and do the thermoforming, we can send the file to the laboratory, and the laboratory can do the next two steps, the 3D printing and the thermoforming. If we want, we can print and externalize just the thermoforming. If the case is too much difficult, we can change our point of view and externalize the conception, the design of the aligner, and do the printing and the thermoforming in our office, or just do the thermoforming in our office. So you can see that collaborative CAD/CAM procedures allow us many different situations, but we are really free to select the situation according to our clinical needs. And I think that's very important because we are able now to choose the way we want to treat patients. We are also able to combine lingual therapy and aligner therapy, because lingual and aligners are not two separate and opposed systems. I think they can work together. Because with the lingual appliance, I know that I can move all the teeth at the same time. A lingual appliance is really excellent for leveling, alignment, dental arch for modification, space creation. It's also excellent for torque control, as well as for angulation control when you use brackets with horizontal insertion. It's later bit tricky if you have to manage severe rotation. And we know that the most difficult point with lingual appliances is the detailing and the finishing. But on the contrary, when you look at the advantage of the aligners, you know that aligners can move only selected teeth. You can select which tooth is going to be moved. I show you that you can have a predictable and reliable movement for a short series of aligners. But, and that's a key point, you need to master the dynamic of the setup and need to understand the setups, the way you think and the way you build your setup. That is really the key point. But when you are able to do that, you can combine lingual and aligners. And I'm going to show you this final case. Jessica, I mean, her smile is not really very nice. She looks, I would dare say that she looks like a witch when she's smiling. Look at it. So she has an anterior crossbite, really narrow and crowded upper arch. Here is the panoramic radiograph. You can see that some teeth are missing. The lateral cephalograms confirm that she presents a class 3 malocclusion. So the first idea was to manage the deep bite, the anterior crossbite and deep bite with this kind of pad on the lower teeth, and to move the upper teeth forward with my upper lingual appliance. But first, focus on the lower arch. The lower arch is quite easy to treat. I know that I'm going to manage a space for an implant on the lower left side. So I bond my appliance, I manage the space, I create the space so that I get this result at the end of the treatment. So it's quite easy. I have done all the procedure by myself. You can see here that I've done the setup and created my lingual appliance in my office so I can bond my upper brackets on the teeth. So this is the initial situation. You can see number one, first picture. The second picture is the day I have bonded the upper appliance. With my 014 night eye, I create space, so I know that I have to move forward the upper teeth. Third picture, it means it's the second appointment with the appliance. I arrange the teeth to have a better alignment. Fourth picture, so the third appointment, Here is the situation, a good improvement with only three appointments. It means 2 activations. 5th pictures, it's the 4th appointment and the 3rd activation. I have 17 square TMA, and on the 6th pictures, 17 by 25 TMA to control the torque, especially the anterior torque. And at the 7th appointment, here is the situation. You can see the blue dots on the wire, because I have to bend a little bit my wire to correct the position of the 21. And at this stage, I think the alignment is good enough. So I remove the brackets. I take an impression, a digital impression, of course. And you can see that I do not remove all the resin pads, because I want to keep a part of these pads to work as attachments. So I use the pads as attachment for my series of aligners. And with 3 aligners, you can see that I want to make the minor detailing to reach this final situation. And I do detailing as well with 3 aligners. This was the final situation after my lingual appliance, and this is after the 3 aligners. And the final resist. Here is the final occlusion after the 3 aligners and, of course, the lingual appliance. And you can see the improvement of the smile. Believe me or not, but it has completely changed her life. So, as I mentioned at the very beginning, I have created a laboratory that I've called Be Cool, because you have to be cool. We have really new opportunity, and digital can be the future of the orthodontist if we accept to take advantage of the digital by controlling the digital flow. It's not always easy. That's why I've developed this Be Cool concept that is underlain by a laboratory and courses. And join the movement and become orthodontic digital designers. And yesterday and the day before, I was with friends and we worked a lot, because it was the really first course to learn how to do in-office setups for aligners and for lingual. So it's a series of 3 courses of 2 days. And I think it's a really new journey. And contact me if you want to join us and be a digital designer of your treatment. What you have to keep in mind, the conclusion of that journey is what? Digital orthodontics can be a versatile process and really individualized process. And I think that makes a big change compared to the current situation, because you can ask yourself this question: is it possible to individualize a standardized process? And the final point, I think there is what I call a therapeutic equation. This equation is based on the doctor, the patient, and the laboratory, the supplier relationship. And at the center of the therapeutic equation, there is a digital world. I think that up to now, the cost of digital and the use of digital was very difficult, so that it was more the skill of companies with the technicians and engineers. But now, all the digital software are becoming more and more user-friendly, and we can do most of the work by ourselves. And that think that we are going to be at the center of the digital world if we accept to learn. And this is one of the topics that is going to be learned during the Sorrento, during the next ESLO meeting in 2022 at Sorrento, Italy. It is held so in Sorrento from the 23rd to the 26th of June. So save the date. And if you want to know more, you can contact me with my email, or you can see the courses on the ACOinstitute.com, and join the movement and be cool. Do not hesitate, contact me. I really thank you for your attention. And I'm available